Hi, in this lecture, we are going to wrap up our study of renal physiology by talking about something called the countercurrent mechanism. Now, up until this point, we talked about the three processes necessary to form urine. The first step was filtration, and remember that happened up here with the glomerular capsule and the glomerulus, and that formed our filtrate. As our filtrate went through the nephron, it was processed. And materials were reabsorbed, meaning they left the filtrate and went back to the blood. Most reabsorption happens in the PCT. We did learn that we lose some water in the descending limb and some salts in the ascending limb. And then we talked about some hormones that affect the DCT as well as the collecting duct for that reabsorption and secretion. And then secretion is when we're moving materials from the blood back into the filtrate so we can get rid of it. And this is how we get rid of a lot of medications and drugs, antibiotics like penicillin, medications, excess potassium, waste products, etc. are going to leave there. And this is how we form our urine. We haven't really talked, though, about the purpose of the loop of Henle. So the loop of Henle is not involved in actually forming urine because we have reabsorption in our PCT and a lot of secretion in our DCT that's actually going to fine-tune it. But what the loop of Henle does is it sets up the ability to concentrate our urine. So when you urinate, your urine can have a lot of water or a little bit of water, and it's due to this loop of Henle. So this is called the countercurrent mechanism because we have fluid flowing in two directions, fluid flowing down the descending limb deeper into the medulla, and then it comes up the ascending limb all the way back up to the cortex. And remember, when it leaves, when it's coming down the descending limb, water leaves that filtrate. And as it makes that turn and comes up, then salts will leave the filtrate. And so this is the components that set up the countercurrent mechanism. And that's why it's called countercurrent. So what is the purpose of this? The main purpose is right here. Its job is to create an osmotic gradient. And so it's going to create a difference in the solute concentration, the concentration of the interstitial fluid from the renal cortex to the medulla. And this is what allows us to concentrate our urine. So this mechanism is set up so that the interstitial fluid of the medulla is going to be much more concentrated. And if we don't set this up with the countercurrent mechanism, we can release all the ADH we want and we will never be able to take water back from our filtrate. So let's look at the anatomy of this. We know we have the descending limb called the thin limb, and that is permeable to water and impermeable to salts. So water will leave the descending limb. If you're taking water away from a solution, it will become more concentrated. So the osmolarity will increase as the filtrate moves down into the medulla. And then it makes the loop and it comes up the ascending limb. Well, the ascending limb is impermeable to water, so water won't leave, but it's going to pump salts out, mainly sodium and chloride. So you have all these active transport proteins that are pumping the salt out into the interstitial fluid. Well, when I pump the salts out into the interstitial fluid, that's going to basically increase the osmolarity of that fluid, which is going to be important because that's why water will leave in the first place. So it's kind of like which came first, the chicken or the egg. You know, the water leaves because the osmolarity is salty, because the salts leave, which allows water to leave. And so we have this change happening where the filtrate gets really concentrated and then salts leave. So as it loops back up, it starts to get really dilute. In fact, by the time it gets to the DCT, the concentration is only about 100 milliosmoles. And so this higher osmolarity of the fluid, the peritubular fluid, the interstitial fluid, is what is going to pull the water out, which, like I said, helps the salts leave. And this is what's going to create this hypertonic medulla. So if we look at this image, again, as those salts leave, you can see the little dots here, that's going to increase the osmolarity, which helps pull water out. and then that concentrates the filtrate so salts can leave. So it's almost like a little positive feedback loop here. But the point of it is to make that interstitial fluid of the medulla hypertonic. And you can see, if we were going to measure it, you can see the filtrate, how it comes in the descending limb. Remember, about 300 milliosmoles is isotonic. As the water leaves, it gets really, really concentrated to about 1200 in a human. And then as we come up the ascending limb, all those salts leave. So by the time it gets back to the DCT, it's very, very dilute. It's only about 100. So what this does is it creates a range of filtrate from 100 at the most dilute to, technically we could concentrate it to 1200 milliosmoles and keep it much more concentrated. And so as we said, as the water leaves, it concentrates it to help the salts leave and create this hypertonic medulla. So if we look at the kidney, notice out in the cortex, and we're looking at the interstitial fluid, we have it around 300, but all the way down close to that minor calyx, it's 1200. And this is because of the countercurrent mechanism. So its job is to create that hypertonic medulla. Now, as the water leaves, remember that concentrates the filtrate so the salts can leave. The salts that leave are going to hang out in the interstitial fluid. So as salts leave, it's going to get more concentrated. But what we know is that technically the salts, all these sodium chloride that leave, they really only get it to maybe about 750 or so. And what actually helps concentrate it even more is urea. So in the collecting tubules in the medulla, urea leaves, and urea is going to go into the interstitial fluid to kind of top it off and make it even more concentrated so it can reach that 1200 milliosmoles. Now, urea is a nitrogenous waste. When we eat protein, we have that amino group, and that gets converted into ammonia, which gets converted into urea. So urea is a waste product from eating protein. If you had a malnourished diet where you were not getting enough protein, then you would actually decrease your levels of urea, which means that your interstitial fluid would never reach 1200. It might hang out around like 750, 800. And so what that means is that's the most concentrated your interstitial fluid of your medulla could be. Now, the vasa recta was an extra blood vessel loop, and it was near these nephrons. They were called the juxtamedullary nephrons. They had a really deep loop in the medulla. And so the blood vessels, the vasa recta, we say they're the countercurrent exchanger. So their job is to pick up any extra water or any extra salt that interferes with maintaining that hypertonic medulla. So this can be a little bit confusing, and so I'll use one of my drawings to help illustrate. We know that the filtrate, when it comes into the loop of Henle, is around 300 milliosmoles. Notice the concentration of the filtrate increases as it goes through that descending limb. And we already said that's because water leaves. So if water does not leave, we could never concentrate our filtrate. And then we know that when it makes that loop, that salts leave. And so when the salts leave, a lot of these salts hang out in this interstitial fluid. So what you see is this white space. This is all the interstitial fluid, or fluid around the peritubular capillaries around the nephron. And so the salts leave, and that's what's going to try to make this interstitial fluid more concentrated. And so as the salts leave, they can keep this interstitial fluid pretty salty. And again, these aren't exact, but you can see that it gets pretty salty. This is the interstitial fluid. So the salts that leave hang out in the interstitial fluid and keep this salty. Any extra salts are going to be picked up by the vasa recta. So again, this is the fluid, this is the interstitial fluid, and it's bathing the whole nephron. Well, because this fluid, these salts come out, that's what allows water to leave. So the water's pulled out because all that fluid is salty. That concentrates the filtrate. So now the salts can leave to keep this salty so that we can have a hypertonic medulla. So why is this important? Because when that filtrate gets back to the DCT, it's coming in at about 100 milliosmoles. That's pretty dilute. Our normal osmolarity, remember, is 300 milliosmoles. So that's very, very dilute. Now, we said, though, that we can actually concentrate the fluid here, the interstitial fluid, to around 1200. And that's because there's urea. Remember, urea, we just said, was a waste product. But some urea actually leaves the collecting tubule, and that's what tops it off to 1200. So the reason why it's a peak of 1200 is because of that urea. So why does this matter? What's the whole point of this? The point of this is that this now gives us a range to control our water reabsorption. So the filtrate comes in at 100, and we know that we have those little water channels, those aquaporins. So we'll just kind of draw them like this. And I'll just draw a bunch of aquaporins coming down the side here. And you should remember that the hormone that controls these water channels is ADH. And ADH is going to open them. Now, what if I don't release ADH? No big deal. It comes in at 100. Very, very watery. If the aquaporins aren't open, it can't leave. So it just leaves at 100. That's pretty dilute urine. That's, very close to water. But what does happen is that you can control the amount of ADH like a dimmer switch. So maybe I only open the first 3 channels. Well, what happens is water's going to leave and it's pulled out of there because the interstitial fluid is hypertonic. If the interstitial fluid was not hypertonic, water would never leave because water has to follow osmotic gradients. And so what this means is that I can have my urine change from a range of 100 to a concentration of 1200, just depending on how many of those aquaporins I open, because I have the range. If I didn't have urea, then I could only concentrate my urine up to about 750, which is actually, it sounds like a lot, but it really isn't. So this whole countercurrent mechanism's job is to give me a range of osmolarity in my interstitial fluid so that I can open ADH, I can release ADH and open these aquaporins, and I get a range of urine so that my urine can leave anywhere between 100 and 1200 milliosmoles in concentration. So that's the whole purpose of this setup here. And then that vasorecta just picks up any extra water or salt to make sure you have this range. So when I'm looking at how do I form, my urine, whether I have dilute or concentrated, well, again, you can see what I was trying to draw earlier. The little dots are showing you your osmolarity. If I don't release ADH, so if ADH is not released, then I don't open those aquaporins. So ADH not being released, don't open the aquaporins, I have a very, very large volume of dilute urine. It would look very, very light, very, very watery. But what happens is I am going to release ADH from my posterior pituitary gland, and that controls the number of aquaporins that opens. The hypertonic medulla is what pulls the water out. So if I release a lot of ADH, I can open all those water channels, all of them throughout, and then I'm going to have my urine leave at about 1200 milliosmoles, which is very, very concentrated and will look very, very dark yellow because there's not much water in there. And so this gives me the ability to change my urine output, the amount of water that's excreted, based on the aquaporins. And as we said earlier, this is called facultative water reabsorption. So ADH is released all the time, by the way. It takes about 45 minutes to inhibit it. So if you were to drink a large glass of water, you would make your blood a little more dilute, and that would actually inhibit ADH. And so if you drink a big glass of water or 2 big glasses of water and time yourself, in about 45 minutes, you're going to have to pee, and you're going to have a very watery, dilute urine, because that's how long it takes to inhibit ADH. But normally we always release it so that we can really control our urine output and our water loss in our urine. So I've seen different numbers for typical urine. They'll say, I've seen probably closer to 800 to 900 is your typical, but we can really concentrate it up to about 1200. To give you an example of this, a camel can concentrate theirs to around 4,000. So they're really good at being able to hold on to water and not lose a lot of it in their urine. And so the purpose of the countercurrent mechanism, which is what we started off by saying, is that it occurs to have an osmotic gradient through the cortex to the medulla, which will then allow you to have a range that you can concentrate your urine, which ultimately allows you to fine-tune and control how much water is lost by the release of ADH and the opening of those aquaporins. So this wraps up our lecture on the countercurrent mechanism.